Hello. Right, beta. So now let us start with the oncosurgery section, that is the cancer surgery section. Herein, I've got a lot of questions in my mind that why cancer occurs. What are the common areas where cancer occurs? Which type of cancers occur in a particular area of the body? So what I am going to do, beta, to learn about this cancer surgery, we'll first try to understand the concepts nicely, right? So keep looking at me and try to understand the concepts. This will take approximately 1 hour just for understanding of the concepts of cancers. And if you pay attention for this 1 hour at each and every word, then you just have to do the writing job in the entire oncosurgery, right? I repeat this in Hindi, beta. oncosurgery में कैंसर्स को समझना बहुत इंपॉर्टेंट है. कैंसर क्यों होता है, कहाँ कहाँ पे कैंसर होने का खतरा ज्यादा होता है, किस तरह का कैंसर होता है, किस तरह से ग्रो करता है, किस तरह से पेशेंट को तकलीफ होती है, किस तरह से हम पेशेंट को अप्रोच करते हैं डॉक्टर होने के नाते, कौन सा इन्वेस्टिगेशन कब करना चाहिए, और फिर किस तरह से पेशेंट के कैंसर की स्टेजिंग करनी चाहिए, और फिर स्टेज के हिसाब से कब कौन सा ट्रीटमेंट करना चाहिए. बेसिकली इन अंडरस्टैंडिंग ऑफ दिस कैंसर we should be knowing that why this cancer is occurring in our body, where the cancers are more common, which type of cancers are more common, how the cancers are growing, and how the patient can present with different symptoms, and how as a doctor we are supposed to approach these patients, and then how we have to investigate these patients, which investigation should be done when, how to stage those cancers, and then what should be the appropriate treatment for a particular stage of cancer. अगला 1 घंटा अगर आपने अच्छे से चीज़ों को समझने की कोशिश की बेटा, तो फिर अपनी ज़िंदगी कैंसर्स में बड़ी आसान होगी समझने में, और गलती होने के चांसेस कम होंगे. ठीक है? So for 1 hour you can just close your eyes, or you can just try to understand this whole story. The most important section of oncosurgery starts now. Right. So, if we have to talk about different cancers in the body, first and foremost thing what we need to understand is why the cancers occur. These cancers can occur because of some genetic reasons, maybe familial stories, maybe some mutation in the genes, or more important to understand is our environmental factors. That means the lifestyle what we lead, that is related to different cancers. Whenever there is any long-term exposure of a carcinogen, then the chances of cancer occurring in that area are high. I repeat this in Hindi, beta. कैंसर क्यों होते हैं? या तो जेनेटिक कारणों से होंगे, या फैमिलियल कहानी होगी, मतलब विरासत में हमको मिली होगी, या किसी जीन में कोई म्यूटेशन हुआ होगा, या हमारे समझने के लिए जो हमारी रोजमर्रा की जिंदगी है, हम अपनी जिंदगी को कैसे जीते हैं, उसका एक बहुत बड़ा योगदान रहता है. कैंसर होने में अगर किसी भी इलाके में बॉडी के लंबे समय तक कोई इरिटेशन रहेगा, कोई किसी इलाके को लंबे समय तक छेड़ता रहेगा, तो वहां की म्यूकोसा कब तक बर्दाश्त करेगी? अपने आप को बचाने के लिए एक दिन वो कैंसर बन जाएगी. Now, if we take a look at the different malignancies in our body, the common malignancies what a surgeon is supposed to know, the GI tract malignancies, the urinary tract malignancies, the malignancy of the thyroid, malignancy of the breast. If we take a look at the GIT and start focusing ki which type of cancer will occur in a particular area of GIT. We know the GIT starts from mouth, pharynx, esophagus, stomach, duodenum, jejunum, ileum, cecum, ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and the anal canal. The type of cancer can either be squamous or adenocarcinoma. It depends on what is the epithelium in that particular area. And we should know that wherever protection is required, God has given us a protective lining, that is a squamous lining. Area near the natural openings of our body require more protection, so God has given a protective squamous lining near all the natural openings of our body. So cancers near all the natural openings of our body will have to be squamous cell carcinoma. Like if we talk about GIT, the oral cavity, the pharynx, the esophagus, that is all lined by squamous. So malignancy in these areas, squamous. Then comes stomach, duodenum, jejunum, ileum, colon, rectum. All these areas are lined by columnar. So adenocarcinoma would be there right from the stomach, duodenum, jejunum, ileum, colorectal region. In the anal canal, again there is a dentate line. Again, there is a natural opening, that is anal opening. So area just proximal to the anal opening will be squamous. In the anal canal, in the dentate line area, above the dentate line it is columnar adenocarcinoma, and below the dentate line it is squamous cell carcinoma. Out of these two, squamous cell carcinoma is more common, so anal cancers are squamous cell carcinoma. Now beta, there was a question on 4th of June that what would be a common malignancy in the cervical part of the food pipe? That means the neck part of the food pipe. Obviously, the answer was squamous cell carcinoma. If we just try to summarize beta, if I ask you oral cancer, squamous, esophagus, squamous, stomach, adeno, duodenum, jejunum, ileum, adeno, colon, rectum, adeno, anal canal, squamous. I hope this is clear beta. Oral, speak out from your vocal cords. मुंह से बोलना है बेटा. Oral, esophagus, stomach, duodenum, jejunum, ileum, colon, rectum, anal canal. Wonderful. Very good. That's like a good boy. Right. So I hope the GI malignancies, the type of cancers are crystal clear in our minds. Similarly, if we take a look at the urinary tract beta, we know God has given us kidneys here. Then there are ureters. These ureters are opening into the urinary bladder, and then there is urethra. If you look at the kidneys, the outer part of the kidneys having the nephrons. There it is the columnar lining. So outer part of the kidney is having adenocarcinoma. And then these nephrons, why they're collecting ducts? They pour their urine into minor calyces, then minor calyces, major calyces, renal, pelvis, ureter, bladder, urethra. The job of these minor calyces, major calyces, pelvis, ureter, bladder, urethra is just to allow passage of urine. So God has given a transitional epithelium in these areas. That means cancers right from minor calyx, major calyx, renal, pelvis, ureter, bladder, urethra, these are transitional cell carcinomas. And in the urethra beta, we know there is an external urethral opening from where the urine comes out. So that is a natural opening. That means area near this natural opening, that means area proximal to the external urethral meatus, that means distal urethra will be having squamous. So distal urethra cancer will be squamous. If we try to understand the outer part of the kidney adenocarcinoma, pelvic calyceal system transitional cell carcinoma, ureter, bladder and proximal urethra transitional cell carcinoma, distal urethra squamous cell carcinoma. Can we repeat this beta? Outer part of the kidney, adeno, pelvic calyceal system, ureter, bladder and proximal urethra, transitional, distal urethra, squamous. Wonderful. एक बार फिर से करेंगे बेटा. We'll do it once again. Outer part of the kidney, adeno, pelvic calyceal system, ureter, bladder and proximal urethra, transitional, distal urethra, squamous. Right. Chaliye. So urinary cancers, right? If you look at the female reproductive tract, you know beta, uterus, cervix, vagina. Vagina is a natural opening. So vagina will be lined by squamous. Then there is cervix. In the cervix, there are two parts. The outside part, ectocervix. Inside part, endocervix. Outside part, ectocervix is lined by squamous. Inside part, endocervix is lined by columnar, adenocarcinoma. And uterus is inside. So endometrium or uterine cancer is adenocarcinoma. फिर से करेंगे बेटा. Vagina is squamous. So squamous cell carcinoma. Cervix, ectocervix, squamous. Endocervix, columnar, adenocarcinoma. Endometrium, that is uterus, adenocarcinoma. Okay, now tell me beta, vagina, ectocervix, endocervix, endometrium. एक बार फिर से करेंगे बेटा. Vagina, ectocervix, endocervix, endometrium. Perfect. Let me revise this once again. The entire story. Oral, squamous. Esophagus, squamous. Stomach, duodenum, jejunum, ileum, colon, rectum, adeno. Anal canal, squamous. Outer part of the kidney, adeno. Pelvic calyceal system, ureter, bladder, proximal urethra, transitional. Distal urethra, squamous. Vagina, squamous. Ectocervix, squamous. Endocervix, endometrium, adenocarcinoma. Right, beta? Now, apart from this, if we take a look at the gallbladder story, gallbladder is lined by columnar, so adenocarcinoma. Pancreatic story, columnar, adenocarcinoma. Prostate, that is also a gland, beta, so columnar, adenocarcinoma. Right. Testicular cancers. Testicular cancers, testis is having germ cell. So in testis we find germ cell tumors, seminomatous, non-seminomatous. Majority are seminomas. Penis. Now penis is outside, beta. So outside God has given protective lining. So outside it is squamous. So penile cancer will be squamous. Thyroid. God has given follicular cells in the thyroid. And malignancy arising from the follicles, they can either be papillary or follicular cancer. Out of these two, papillary cancers are more common. So thyroid cancer most common is papillary cancer. Breast cancer. Inside the breast there are three things: duct, lobule and stroma. Stromal malignancies, sarcomas, not carcinomas. Carcinoma from the duct or lobule. So in breast cancer, either it is a ductal cancer or lobular cancer. 80-85% are ductal cancers, and that is also adenocarcinoma. Right? फिर से करेंगे बेटा. Oral, esophagus, squamous. Stomach, duodenum, jejunum, ileum, colon, rectum, adeno. Anal canal, squamous. Outer part of the kidney, adeno. Pelvic calyceal system, ureter, bladder and proximal urethra, transitional. Distal urethra, squamous. Gallbladder, pancreas, adeno. Prostate, adeno. Penis, squamous. Testis, germ cell, seminoma. Thyroid, papillary thyroid cancer. Breast, invasive ductal carcinoma, adenocarcinoma. Once again we'll do it, beta. Oral, esophagus, squamous. Stomach, duodenum, jejunum, ileum, colon, rectum. Anal canal. Outer part of the kidney. Pelvic calyceal system, ureter, bladder and proximal urethra. Distal urethra. Distal urethra. Prostate. Penis. Testis. Testis germ cells. Seminomas. Right. Gallbladder, pancreas. Adenocarcinoma. Thyroid. Papillary. Breast. Invasive ductal carcinoma, adenocarcinoma. Right? Very good. Let's have a big round of applause for all of you. So see, on 17th of December, we'll get one question from this. And it simply depends on the concepts, on the understanding. The lining is deciding the cancer. Right? Okay, beta. Chaliye. Now, what are the common areas where you will be finding cancers? For example, if we take a look in GIT, what are the common areas where do you feel that somebody is going to irritate more? Oral cavity, people who have a habit of chewing that tobacco gutka khate na beta, so that is going to irritate the buccal mucosa, and long term irritation will lead to cancer. So oral cancer would be a very common malignancy. Esophagus will also be common. Stomach will be very common. Now duodenum, jejunum and ileum, these would be very rare because continuously the peristalsis is moving. So the peristalsis will not allow the carcinogens to stay, right? In the colon rectum beta, what is the reservoir where the fecal matter stays for long period of time? It is the rectum and the sigmoid. The fecal matter stays there. So the chances of irritation to the rectal mucosa and sigmoid mucosa will be more. So the commonest site of malignancy in the colorectal area will be rectosigmoid. And then anal cancers would be common. So in the GIT, oral cancers, esophagus, stomach, rectosigmoid, anal canal cancers. These would be the common cancers. Apart from this, we can find gallbladder cancer and pancreatic cancer also. Now, in the urinary tract beta, kidney, ureter, bladder, urethra. So, ureter, continuously urine is moving. Chances of malignancy negligible. Urethra, the urine is coming only for a less period of time. So, urethral cancers are also very rare. That means we can find kidney and bladder cancers. Now tell me beta, look at me, tell me which out of kidney and bladder will have more chances of stasis of urine. Kidney bladder में से कौन सा इलाका है बेटा जहाँ पे यूरिन ज़्यादा समय तक रुकता है? Very good, bladder. So which cancer is more common? Bladder cancer is more common, right? Prostate cancer is very common in elderly males. Actually, that is considered as a part of the aging process. उम्र का हिस्सा मानते हैं prostate cancer को. It is said that if somebody, suppose God comes in somebody's dream and he asks that, see gentlemen, I have to give you one cancer. Which cancer would you like to have? Then the gentleman would ask, okay, give me prostate cancer. Prostate cancers are very slow growing cancers. They are considered as a part of aging and they are very common after 70-80 years of age, right? Almost 70% of males after 80 years of age suffer from prostate cancer, right? Penile cancer, multiple sexual partners, poor hygiene, this will be causing those penile cancers. Testicular cancers, most commonly related to undescended testis. Thyroid malignancies, these are the commonest endocrine malignancies. Breast cancer is the commonest cancer in females, right? 1 out of every 8 female suffer from breast cancer. So we are going to talk about these different cancers. Now let us take a look that why this cancer occurs. Beta, apart from the genetic causes, apart from the familial causes, let us focus on the irritative factors. Like oral cancer की अगर हम बात करते हैं, oral cancer would be common in those people who have a habit of chewing the tobacco. जिन लोगों को तंबाकू खाने की आदत है, उनको मुंह का कैंसर होता है ना? So smoking, that is also something going to be related to. ध्यान से सुनना बेटा, each and every word is going to be very important here, right? Apart from this, now if suppose we come in the esophagus, smoking, alcohol, smoked food is the barbecue food, tandoori food, right? Tandoori chicken, the black tar on that tandoori chicken, that is considered as more dangerous than smoking to cause this esophageal and stomach cancers. Okay. Apart from this, there can be different pathologies in the esophagus which can cause chronic irritation, like achalasia cardia, traffic jam in the esophagus. The food material will be staying in the upper esophagus and will be irritating the esophageal mucosa. GERD, gastroesophageal reflux disease, where the acid from the stomach refluxes into the esophagus and causes burning of the lower esophagus, where Barrett's esophagus can occur, where the squamous lining changes into columnar. So if it is a GRD Barrett's, then adenocarcinoma in the lower esophagus. Apart from this, Zenker's diverticulum can also cause esophageal cancers. Human papilloma virus is a common culprit for cancers near the natural openings of the body. ये HPV भाई साहब जो हैं, ये बॉडी की जितनी भी नेचुरल ओपनिंग्स हैं उनके आसपास खूब हल्ला मचाते रहते हैं. इसलिए malignancy near the natural openings of the body is commonly related to this human papilloma virus, whether it is oral cancer, esophageal cancer, anal cancer, vaginal cancer, cervical cancer, distal urethral cancer. All these malignancies would be linked to human papilloma virus. Radiation. If somebody is receiving radiation, then that can also cause cancer. Sometimes some syndromes can be associated. Like in esophagus, there is a Plummer-Vinson syndrome, which can be associated. So we were just talking about the risk factors for various cancers. Oral cancer, tobacco chewing, smoking, esophagus, smoking, alcohol, smoked food, eclasia cardia, GRD, Barrett's, Zenker's diverticulum, human papilloma virus, radiation, and some syndromes like Plummer-Vinson syndrome. Stomach cancer, again related to people who eat lot of irritative food, like suppose that smoked food, canned food, स्पाइसी फूड, हाई सॉल्ट. जो लोग नमक ज़्यादा खाते हैं, नमक से नमक लगता है स्टमक की म्यूकोसा को. पिकल, अचार जो लोग ज़्यादा खाते हैं, दैट पिकल कॉजेज इरिटेशन ऑफ द गैस्ट्रिक म्यूकोसा. Those who take less vitamins and antioxidants in diet, that means those who take less amount of fruits and vegetables. जो लोग फल और सब्जी कम खाते हैं, इसका मतलब विटामिन एंटीऑक्सीडेंट कम खाते हैं. By taking less vitamins and antioxidants, you are making the mucosa of every part of your body weak, so it can easily be attacked by the carcinogens. That is the role of fresh fruits and vegetables. That is how our elders keep on telling us, eat healthy food, right? If you eat healthy food, it will help in making your mucosa strong so that it cannot be acted easily upon by the carcinogens. Apart from this, in the stomach there are various pathologies like chronic gastritis, type A autoimmune gastritis, type B H. pylori gastritis, Menetrier's disease, reflux gastritis where patient has undergone some gastric surgery, gastric polyps. All these can be associated with stomach cancer. Colorectal cancer. Now, colorectal cancer more common in rectosigmoid. Those individuals who take more amount of red meat, जो लोग लाल मांस खाते हैं. Those who take more amount of animal fat. Those who take less amount of fiber in diet, less amount of vitamins, antioxidants in diet. This is going to cause constipation as well. So the fecal matter, the carcinogens will be staying in the rectum sigmoid for a long period of time. Apart from this, various polyps in the colon, like a condition familial adenomatous polyposis, which may be associated with various other syndromes, Gardner syndrome, Turcot syndrome, and there is another Lynch syndrome. All these can be associated with colorectal cancers. Apart from this, radiation. Patients who have undergone cholecystectomy. So now there is no place where the bile can get stored. So bile salt, bile acid, they keep on coming into the colon. And this bile acid can cause destruction of the colonic mucosa, can lead to cancer. Right. That means there are high risk of colon cancer after cholecystectomy. Fine. Anal canal cancers, human papilloma virus, people who have got bad habits, right? Anal intercourses, they have got more chances of this anal canal cancer. Gallbladder cancer, Somebody is irritating the gallbladder mucosa for a long period of time, like stones inside the gallbladder, porcelain gallbladder, typhoid, adenomatous polyps inside the gallbladder. That will cause gallbladder cancer. Pancreatic cancer, smoking, diabetes, chronic pancreatitis, hereditary pancreatitis. Anybody who is causing irritation of the pancreas will have high chances of developing cancer later on. Right, so this is the risk factor story of GI cancers. Now urinary cancers, kidney cancer, bladder cancer. Smoking is the commonest cause for both, because a person who is a smoker, the toxins are getting absorbed into his circulation. These toxins are going through the circulation into the kidneys and they are getting excreted through the kidneys. So the kidney mucosa and the bladder mucosa is coming in contact with these carcinogens for a long period of time. And please do remember, beta, it is not a one-day exposure of carcinogen which is going to cause cancer. It is not like that if somebody smokes 500 cigarettes in one day, he will develop the cancer next day. But if somebody is smoking 20, 30, 40 cigarettes on a daily basis for years together, 10, 15, 20 years, then this mucosa is continuously getting irritated, and a day will come when this mucosa will try to protect itself and it will undergo rapid mitotic changes and can lead to cancer. Kidney and bladder cancer very commonly related to smoking. Apart from this, kidney bladder cancer is also considered as an industrial disease. People who are working in some industries where there is use of some chemicals, some dyes, some contrast. For example, if you look nearby yourself, there may be carpenters, painters, polish workers, shoe polish wala. So what is happening? Whatever chemicals are there, whether it is a painter polish, whether it is the paint on the walls, whether it is the shoe polish, these chemicals are continuously getting absorbed through the skin into the circulation of these occupations. And then these chemicals are going through the urinary tract, irritating the urinary mucosa for a long period of time. Here I would like to tell you the story, the life of a painter. A painter who earns bread and butter for his family by painting the walls for 350 days out of 365 days in a year. Just imagine, when he is painting the wall, the chemical in the paint which is liberated is getting absorbed into his skin, and through the skin it is coming into his circulation, and the circulation is going through his kidneys. So this chemical is causing irritation of the kidneys and the bladder. That is why he is having high risk of cancers of kidney and bladder. I repeat this in Hindi, beta. एक पेंटर जो है, उसकी जिंदगी को अगर देखें, वो अपने बच्चों का पेट दीवारों पे पुताई करके भरता है। साल के 365 में से 350 दिन पुताई करता है, तब जाके अपने बीवी बच्चों का पेट भर पाता है। अगर वो 365 में से 350 दिन पुताई कर रहा है, तो जो केमिकल उस पेंट में है वो उसकी स्किन से एब्जॉर्ब हो रहे हैं, उसके ब्लड में जा रहे हैं, ब्लड किडनी पे जा रहा है, और वहां से ये केमिकल उसके किडनी, यूरेटर, ब्लैडर, यूरेथ्रा में जा रहे हैं। उसकी किडनी और ब्लैडर इन केमिकल्स को ज़्यादा एक्सपोज हो रहे हैं, इसलिए किडनी ब्लैडर कैंसर होने का खतरा इन लोगों में ज़्यादा होता है। Apart from this, if there is a stone present for a long period of time in the kidney bladder, that can also cause cancer. People who have a habit of using analgesics just like that, that can also cause damage to the kidney mucosa. One syndrome can be associated with kidney cancer, that is von Hippel-Lindau syndrome. Right. If we come to the prostate cancer, prostate is a part of the aging. So usually it is related to hormones, androgens. In case of males, it is a prostate cancer which is related to hormones, that is androgens. In case of females, it is the breast cancer which is related to hormones, that is estrogen. So prostate cancer, androgen story. Breast cancer, estrogen story. Right? Penile cancer, poor hygiene. Those people who do not clean their glands I repeat, those people who do not clean their glands on a regular basis, the smegma gets collected there, which leads to chronic irritation, and that can lead to cancer. People who enjoy multiple sexual partnerships, they also have high risk of cancer. Human papilloma virus would be a high risk for this cancer. There may be various pre-malignant lesions in the penis like leukoplakia, erythroplakia, and so on. They can lead to penile cancer. Testicular cancer, most common is the seminoma, and the reason for testicular cancer, most often it is the undescended testis. So this is about the risk factors for urinary cancers. Now thyroid cancer. Thyroid cancers developing from the follicle, most common are papillary, and papillary cancers most common are related to radiation, especially if a small child less than 5 years of age has received multiple x-rays of the neck or multiple CT scans of the neck, then this radiation exposure can lead to papillary thyroid cancer in future life. Follicular thyroid cancer is most often related to long-standing endemic goiters. Long-standing endemic goiters. Breast cancer. We know the genes in breast cancer, BRCA1 and BRCA2, breast cancer gene 1 and 2, BRCA1, BRCA2. Apart from this, breast cancer is a familial cancer which runs in families. For example, if the mother had cancer, or mother's mother had cancer, or mother's sister had cancer, or own sister had cancer, or she herself had cancer in one breast, then the chances of developing cancer in the other breast are high. I repeat this in Hindi beta. ब्रेस्ट कैंसर की बात करते हैं तो जेनेटिक्स BRCA1, BRCA2 की बात करते हैं, फैमिलियल बात करते हैं कि ब्रेस्ट कैंसर फैमिलीज में रन करता है. अगर माँ को ब्रेस्ट कैंसर था, अगर माँ की माँ को ब्रेस्ट कैंसर था, माँ की बहन को ब्रेस्ट कैंसर था, खुद की बहन को ब्रेस्ट कैंसर था, या खुद को ही ब्रेस्ट कैंसर था, तो दूसरी ब्रेस्ट में कैंसर होने का खतरा ज़्यादा होता है. And this is not only the maternal side, it is also related to the paternal side. If the father's mother had cancer in the breast, then also the chances of developing cancer in the breast are high. Apart from this, breast cancer is related to estrogen. Those females who are having more estrogen exposure, वो लड़कियां, वो लेडीज जिनमें estrogen का exposure ज़्यादा होता है. Now these hormones causes hyperplasia of cells in the breast. If there is a more hormonal stimulation, then this hyperplasia will not be a controlled or typical hyperplasia, but it will become uncontrolled atypical hyperplasia, more mitosis, more pleomorphism. This atypical hyperplasia can advance into carcinoma in situ, microinvasive cancers, and frank invasive cancers. How more estrogen exposure? If we consider two girls, one who started having menstrual cycle at 10 years of age and she achieved menopause at 50 years of age, versus a girl who started having menstrual cycle menarche at the age of 15 years and she achieved menopause at 45 years of age. So duration of exposure of estrogens, in the first one 10 years to 50 years, that means 40 years of exposure. In the second one 15 years to 45 years, that means 30 years of exposure. So obviously 40-year exposure is more than 30-year exposure, so the chances of cancer developing in a lady who is having early menarche and late menopause, the breast cancer risk is high. Same way, a nulliparous female, exposure of hormones will be more. Apart from this, post-menopausal obese females, if after menopause the lady is obese, obese means fat, there is increased conversion of steroids in the fat into estrogen. So if the lady is obese, more fat, more steroid getting converted to estrogen, so estrogen exposure will increase. The chances of cancer in a post-menopausal obese female will be high. Same way, sometimes the females, even after menopause, they want to retain the pre-menopausal functions. अगर मीनोपॉज भगवान ने दे दिया है, लेकिन ये महिलाएं चाहती हैं कि नहीं, हमें तो वो जिंदगी ज़्यादा पसंद थी, तो these ladies might start taking hormone replacement therapy. So again, they are exposing themselves to more amount of estrogen. So the chances of breast cancer will be high. So this is just a story related to the risk factors of different cancers. नींद तो नहीं आई बेटा, सो तो नहीं गए थे, आँख खोलिए, right. So what we discussed were the different risk factors in different cancers. सारे cancers के risk factors एक साथ हमने discuss कर लिए. अभी what is the advantage of doing this? When we'll be writing these, then we'll be remembering these stories. अच्छा, ये इसलिए होता था, ये इसलिए होता था, ये इसलिए होता था, right? Okay, चलिए. So I hope you will be able to remember these different risk factors. If you look at all the risk factors, beta, one bottom line: long-term exposure of a carcinogen, long-term irritation, that is going to lead to cancer, right? Chaliye ji. Now let us try to understand that how these cancers can grow. Pathology of these cancers. They can grow as a mass or a polyp, or they may grow as a ulcer. So we can define them as ulcerative lesions or proliferative lesions. Like in the oral cancer, there might be an ulcer in the oral cavity, which if present for a long period of time, it is not getting healed. We have to investigate because we have to rule out malignancy. There might be a growth coming out from the oral cavity. So that can be one of the types how the cancers grow. In the esophagus, usually it grows as a polyp. In the stomach also it grows as a mass. Generally this mass can ulcerate also, so we call it as ulceroproliferative. In colorectal area, the right-sided, that means the cecum ascending colon, they are more ulcerative in nature. Left-sided, that is rectosigmoid, they are more of a proliferative in nature. So the chances of traffic jam in the left-sided colorectal cancers are more. Anal canal cancers grow as a mass. Gallbladder cancer grow as a mass. Pancreatic cancer grows as a mass or a tumor. Kidney cancers, bladder cancers. Kidney, usually there is a ulcerative lesion, but patient can also have that proliferative mass. So kidney masses can be there. Bladder cancer also grows as a mass inside. That is a frond-like mass. And then prostate cancer grows as a mass. Penile cancer can be an ulcer or a growth on the penis. Testicular cancer grows as a mass, causes enlargement of the scrotum. Thyroid cancer grow as a mass, present with neck swelling. Breast cancer grow as a mass, presents as breast lump. Right? Now, how these malignancies can present? We have been talking about that they grow as a mass, as a mass, as a mass, as a mass. So mass means swelling. So swelling, lump. For example, in GI malignancies, there may be lump here. Right? Also, one more thing which I would like to tell you in the presentation, beta. Whenever we are talking about any cancer, cancer is what? When the cells are undergoing rapid cell division, rapid mitosis, cells are dividing very fast. That is how they are multiplying and growing as a mass. So it is not only the cells which are dividing, but it is also the growth of the blood vessels. It is the blood vessels also which are growing. And many times, because of this growth, the blood vessels can break, which leads to bleeding. So majority of these cancers can present with bleeding also. Whether it's an oral cancer, esophageal cancer present as a mass, so it will be causing a traffic jam situation in the esophagus. If there is a traffic jam in the esophagus, the patient will not be able to swallow nicely, so dysphagia. Stomach can grow as a mass, can bleed. If bleeding occurs inside the stomach, this blood can go through the pylorus into the duodenum, jejunum, ileum, colon, rectum, anal canal. By the time this blood comes out of the anal canal, it has traveled through a long journey, so the red hemoglobin will not be red. It will disintegrate into brown and black. So what the patient passes is a black. mixed with mucus, that is tarry, black tarry stool, melena. So stomach cancer patient can present to you with melena. Sometimes stomach cancer, if there is bleeding inside the stomach, patient can present with blood and vomiting, hematemesis. Colorectal cancer. Colorectal cancer is present with bleeding. The commonest presentation is bleeding per rectum, right? Anal canal cancers, as a mass at the anal verge, that can also bleed. Gallbladder cancer. Now, gallbladder cancer, generally there is a mass inside the gallbladder, and usually what happens, in the early stage we are not able to know about this mass, but gradually this mass infiltrates into the liver, goes into the liver. And when the liver is getting involved, then the blood vessels and bile vessels in the liver, they are getting exposed. So bile is getting mixed with blood. Bile in blood, jaundice. Gallbladder cancers can present with jaundice or maybe a mass in the right hypochondrium. Pancreatic cancers, they are quite inside. So they also, when they grow, they can create a traffic jam in the common bile duct. So that can also lead to jaundice. That is the presentation of GI cancers. Kidney cancer, bladder cancer. The commonest presentation is painless hematuria. There is bleeding in the urinary tract in kidney and bladder cancer, and this blood comes out in urine. The commonest presentation of kidney bladder cancer is painless hematuria. Prostate cancers do not present with any symptoms. That is just a part of the aging process. Now, when the prostate cancer grows, if it spreads here and there, like most commonly it goes into the bones, lumbar vertebra. So patient comes to us with backache, right? 80-year-old male with low backache. Prostate cancer, bony metastasis. Penile cancer. Penile cancer patient will come to your OPD with something on the penis, and you will look at the penis and you can make out, there is something, right? Testicular cancer. Cancer growing in the testis, enlargement of the testis, scrotal enlargement. Patient comes to you with a scrotal enlargement, right? And any patient coming with scrotal enlargement, the first thought which comes to our mind, this can be a hydrocele, right? For hydrocele, you do the trans-elimination test, and if trans-elimination is negative, that means there is no fluid inside. You might be tempted to put a needle into the scrotum, but never put the needle in the scrotum, because if it is a tumor and you take the needle out, you can spill the tumor cells somewhere in the scrotum, right? Thyroid malignancies, they present with a swelling in the neck. Breast cancer, breast lump, usually in the upper outer quadrant. However, since majority are ductal cancers, so we can even find circumferential retraction of nipple. Sometimes we can find bleeding from the nipple. Sometimes there is indrawing of the skin. Sometimes the cancer cells infiltrate into the subdermal lymphatics, which gives a pudy orange appearance. Sometimes the breast cancer goes into the axillary lymph nodes. Traffic jam in the axillary lymph nodes can present with lymphedema of the arm. And if we just try to summarize the clinical presentation of all the cancers: oral cancer, mass, bleeding; esophagus cancer, polyp, traffic jam, dysphagia; stomach cancer, mass, bleeding, melena, hematemesis; colorectal cancer, bleeding per rectum; gallbladder cancer, jaundice; pancreatic cancer, jaundice; kidney bladder cancer, painless hematuria; prostate cancer, low backache; penis cancer, growth on the penis; testis cancer, scrotal enlargement; thyroid cancer, swelling in the neck; breast cancer, lump in the breast; circumferential retraction of nipple, bleeding from the nipple; pudy orange appearance of the breast; lymphedema of the arm. These can be the presentations. All the cancers, clinical presentations. Done. Wow. Now, how to approach these patients? This, what we have discussed, is the overview of cancers. Now let us see what should be our approach as a doctor. Beta, 17th of December is your exam, and nobody on the earth has the power to defeat you, right? You will have that belief inside you that yes, nobody has the power to defeat me on 17th of December. I am going to pass. Now when you pass the exam, January, you will be applying for your registration with medical council, and February you are in the hospital, working in the hospital, and you are wearing that white coat and the stethoscope around your neck. Very prestigious white coat and that stethoscope. Right, beta. Depending on how the patient comes to you, your approach will change. For example, if there is a ulcer in the oral cavity or a mass in the oral cavity, you will do the clinical examination, right? And herein, if you are suspecting something, you can take a direct biopsy from the growth, right? And the biopsy, the pathologist will tell you this is a squamous cell carcinoma, right? Okay. Before we talk about this investigative approach, let us also take a look at how this cancer spreads, so that when we are deciding our approach, that what should be done when, we should be very clear that which cancer can spread how. So beta, whenever we talk about carcinomas or cancers, they can spread either locally. Along with this, they can go into the lymphatics, through which they go to the draining lymph nodes. So lymph node enlargement can be there, and they can also go into the blood vessels. Obviously, they will be going into the vein. If there is a cancer here, artery is bringing the blood, vein is taking the blood. So cancer here is not going to go into the artery here. It is going to go into the vein. And through this vein, it will be going into the circulation, and from there it can spread to any part of the body, right? So that will lead to distant metastasis. दूर दराज के क्षेत्रों में कैंसर फैल जाएगा. I repeat this, beta. Whenever we are talking about carcinoma, the carcinoma can spread either locally, or it can go into the lymphatics, which will cause enlargement of the lymph nodes, or it can go into the vessels. That means it will be going into the circulation, and then it will be spreading through blood to distant parts of the body, distant metastasis, right? For example, again, let us take a look at the spread of all the cancers. Oral cancer, it can spread locally. Suppose there is a cancer in the buccal mucosa. It will spread to the layers here, and it can even involve the mandible. Through lymphatics, the entire head and neck area, beta, that is drained by the neck lymph nodes. In the neck, beta, in ENT classes we'll read there is a submental 1A, submandibular 1B, then 2, 3, 4 lymph nodes. They are upper, middle and lower jugulo-digastric deep cervical lymph nodes. 5, posterior triangle of neck lymph nodes. 6, pretracheal lymph nodes. 7, mediastinal lymph nodes, right? So head and neck cancers, they drain into neck lymph nodes. So if there is malignancy in the oral cavity, it would be going and causing enlargement of the neck lymph nodes, right? Thyroid malignancy also, it is going to involve the neck lymph nodes. Here it is a pretracheal lymph node or the delphic lymph node, which is close to isthmus of the thyroid, which gets involved, right? Breast cancer, this goes into the axillary lymph nodes and to some extent into the internal mammary lymph nodes, right? Okay. Locally, if we talk about beta, then let's do in the same sequence. Oral cancer, local spread, lymphatic spread, and through blood. It can go to distant organs like lungs. Lung metastasis can occur. Then esophageal cancer, local spread. The story starts in the mucosa. It can involve the submucosa, muscle. There is no serosa in the esophagus. So once the muscle has been involved, then it will involve the adventitia or the surrounding organs. Through lymphatics, it will be going into the regional lymph nodes in this area. And through blood, this cancer would be going into the liver and the lungs. Stomach cancer. Stomach cancer starts in the mucosa. Then it can involve the submucosa, muscle, serosa, adjacent organs. If the cancer is in the proximal part of the stomach, adjacent organ close to this is spleen. If the cancer is in the distal part of the stomach, adjacent organ close to distal stomach is pancreas. Through lymphatics, the cancer involves first the perigastric lymph nodes, then the intermediate and then the principal lymph node. In GIT we know foregut, midgut, hindgut, foregut celiac, midgut superior mesenteric, hindgut inferior mesenteric. So principal lymph node involved in foregut malignancy would be the celiac lymph node. Apart from this, if it spreads through blood, then it most often goes to liver and lungs. In stomach cancer, there is another type of spread which we call as the transcoelomic spread or direct peritoneal spread. In this transcoelomic spread, sometimes the cancer cells can break from the stomach and spill into the peritoneal cavity. They might get deposited here and there on the peritoneum, which is called as peritoneal deposits. They might get deposited around the umbilicus, Sister Mary Joseph nodule. They might get deposited on the functional ovary, Krukenberg tumor. They might get deposited on the anterior wall of rectum, Blummer's shell. Sometimes in the stomach cancer, when the cancer is spreading through lymphatics, it can even involve the left supraclavicular lymph node, which is called as Virchow's node or Troisius sign. It can even involve the anterior axillary lymph nodes, which is called as the Irish node. So this is how the stomach cancer can spread. Same way colorectal cancers, mucosa, submucosa, muscle, serosa and the adjacent organs locally through lymphatics. If it is a cancer in the midgut, principal lymph node superior mesenteric, hindgut, inferior mesenteric. Through blood, if you look at the veins draining the midgut and the hindgut, midgut is drained by superior mesenteric vein, hindgut is drained by inferior mesenteric vein. Superior mesenteric vein joins with the splenic vein to form the portal vein. So, if there is a cancer in the midgut and it has gone into the superior mesenteric vein, then it will be going into the portal vein and into the liver metastasis. If it is a cancer in the hindgut and it goes into the vein, inferior mesenteric vein, this opens in the splenic vein and splenic vein opens in the portal vein and portal vein opens in the liver. So hindgut cancer, inferior mesenteric vein, splenic vein, portal vein, liver metastasis. Colorectal cancers spread commonly through these superior inferior mesenteric veins, and 33% of colorectal cancers, when they come to us in the hospital, they already have got metastasis in the liver. Right? So colorectal cancers, they have got very high chance of liver metastasis. Right? Now, if we suppose take a look at the kidney cancer. Now, kidney cancer, there is a capsule around the kidney. So, cancer inside the kidney will involve the capsule, can involve the adrenal gland, and then the adjacent organs. Through lymphatics, the regional lymph nodes, and through blood. If kidney cancer has to spread via blood, then this cancer will go into the renal vein. Now, beta, right renal vein, left renal vein. They both are opening into the inferior vena cava. And inferior vena cava opens into the right atrium. Right atrium opens in the right ventricle. Right ventricle, pulmonary artery, lungs. So if there is a cancer in the kidney, it will spread into the renal vein, IVC, right atrium, right ventricle, pulmonary artery, lungs. So the commonest site of distant metastasis for kidney cancer will be lungs. What you are doing, beta, you are just trying to develop the concepts. Why colorectal cancers are going to liver, why kidney cancers are going to lungs. The story is absolutely simple. Cancer from any organ will be spreading through its vein, and then you have to just hold on to the vein, just pakdo the vein and see where the vein is opening, and that would be the commonest site of distant metastasis. Same way, beta, bladder cancer also, it can involve the mucosa, submucosa, muscle, adventitia, adjacent organs. It can spread to the lymph nodes nearby, the iliac lymph nodes, and through blood. It will also be going into the inferior vena cava, so lungs will be the common site of metastasis. Prostate cancers, they can spread locally, and when they spread locally, they spread upwards and laterally. Through lymphatics, they go to obturator lymph nodes, and through blood, they again go to the iliac lymph nodes. Through blood, they go to the iliac veins, and then the inferior vena cava, and then the lungs. Penile cancer story, beta, they can spread to the cavernosas. The inguinal lymph nodes will be involved, and through blood again they'll be going to lungs. Testicular malignancy, beta, locally the testis cancer can spread into the scrotum. Through lymphatics, it will be involving the pre and para-aortic lymph nodes. You know that gonadal artery is a direct branch of abdominal aorta. That means testicular artery is a branch of abdominal aorta. So the lymphatics will be situated on the abdominal aorta. That is why testicular lymphatic drainage is to pre-para-aortic lymph nodes. And these testicular veins, the right testicular vein opens in the inferior vena cava, left testicular vein opens in the left renal vein, and left renal vein opens in the inferior vena cava in the right atrium, right ventricle, pulmonary artery, lungs. So that is how pulmonary metastasis, lung metastasis will be common in testicular cancer, right? Thyroid cancer, locally it can involve the adjacent organs, lymphatics, the pretracheal and the neck lymph nodes, and through blood it can also go into lungs and the bones. Prostate cancer and breast cancer, these are the two cancers which commonly spread to bones via Batson's vertebral plexus of veins, right? Okay. So, this is basically the whole story. Breast cancer can spread locally. It can come anteriorly and involve the skin of the breast, and posteriorly it can go and involve the pectoralis major, minor muscles, the ribs and the intercostal muscles, that is the chest wall. Through lymphatics, axillary lymph nodes and internal mammary lymph nodes, and through blood, it spread to liver, lungs, and most importantly to bones. So this is the whole overview about these different malignancies, right? Chaliye. Once you get this overview, before we move ahead, let us just summarize what we have discussed. We have discussed what different cancers we are going to study. We have discussed what will be the histological type of cancer in a particular part of the body. We have discussed the risk factors why this cancer develop in that particular area. We have discussed how the cancers grow pathologically. We have discussed how these patients present to us with various symptoms, though early stage of all the cancers is asymptomatic. That is the biggest challenge. Body के अंदर कैंसर ग्रो कर रहा है और पेशेंट को हवा भी नहीं है. If the patient comes to us at early stage, he can be treated at early stage and he can be cured. But the major challenge why we get fear about this name cancer, because the patient does not come to know about it, and by the time patient comes to us, the cancer is already spread, and that may be too late to treat that cancer, right? So we have discussed about the symptoms of these different cancers. We have also discussed that how these different cancers spread locally through lymphatics and through blood, right? Chaliye ji. Then we talk about how we should approach these patients. If the patient was presenting with a cancer in the oral cavity, maybe ulcer or growth, you can take a direct biopsy. If the patient was presenting with dysphagia, then you do a barium swallow. And if you see a filling defect or rat tail appearance on barium swallow, then you can do a upper GI endoscopy, do a biopsy and prove it as cancer. If the patient comes to you with stomach cancer and abdominal mass, any patient presenting with mass in the abdomen, whatever is the age, first investigation is ultrasound of the abdomen. If you find a mass in the stomach on ultrasound abdomen, you can do upper GI endoscopy and take a biopsy. If the patient presents with melena, Then you do stool test for occult blood. If that is positive, that means it is a upper GI bleed. Then you do upper GI endoscopy and you can take a biopsy and prove it as cancer. Colorectal cancers, bleeding per rectum, elderly people, do a colonoscopy, see the cancer and take the biopsy. Gallbladder and pancreas, these are the areas where endoscopy would be difficult. So if the patient comes to us with jaundice, the first investigation is LFT, then we do the ultrasound. If we suspect any mass, then since endoscope cannot be taken into the gallbladder and the pancreas, so we prefer doing a CECT. Percutaneous biopsies are not recommended because if you try to take a percutaneous biopsy, you are going into the peritoneal cavity, you take a biopsy from the cancer, and now when you are withdrawing the needle, at that point of time the cancer cells can spill in the peritoneal cavity. So you can disseminate the cancer. That is why we avoid taking percutaneous biopsies wherever there is risk of spillage of cancer. However, those areas in the body which are outside, you can take a direct biopsy, no risk of spillage of cancer. Those areas in the body where you can pass the endoscope, you can do a endoscopy biopsy without spillage of cancer. So, investigation of choice, if we take a look beta, oral cancer, esophagus cancer, stomach cancer. Oral cancer, direct biopsy, esophagus endoscopy biopsy, stomach endoscopy biopsy, colorectal endoscopy, colonoscopy and biopsy. Anal canal cancer is outside, direct biopsy, right? Okay. Now, urinary cancers, painless hematuria. 70-year-old male, painless hematuria. First investigation, examination of urine to look for cancer cells. If cancer cells are present, there can be a cancer in the bladder, or if not in the bladder, might be a cancer in the kidney. So next step here would be do a cystoscopy, pass an endoscope in the bladder. If you see a cancer inside the bladder, you can directly take a biopsy, cystoscopy and biopsy for bladder cancer. But suppose there is no cancer inside the bladder, but cancer cells are positive in urine. So now this would be a kidney cancer. In kidney cancer, if it is the outer part of the kidney, we cannot pass any endoscope into the outer part of kidney. And we cannot take a percutaneous biopsy. So we do a CECT, right? For prostate cancer, we can do a transrectal ultrasound guided prostatic biopsy. Penile cancer, penis is outside, direct biopsy. Testicular cancer, needle into the scrotum, no. So there also we go ahead with CECT. Now, thyroid malignancies, ultrasound guided FNAC can be done without spillage. Breast cancer, breast lump, triple assessment, CRP, clinical, radiological and pathological. Best would be taking a needle biopsy. So that is how the investigation of choices can be done for different cancers, right? Okay, G. Once we have done the investigations and proved that yes, this is a cancer, now before jumping on to the treatment, it is important to know how far the cancer has spread. So we have to do staging of these cancers to know the local spread in the area. We do investigations like CT and MRI. Okay. Now here, when should we do CT? When should we do MRI? All those areas in the body where we have to know about the soft tissues, muscles, nerves, vessels. MRI is a better investigation for soft tissues, muscles, nerves, vessels. CT is a better investigation for parenchyma like liver, kidney, spleen, parenchyma. CT is better there, right? Okay. So if I just try to take a look, we have proved the cancer and now we have to do the staging. Just to remember beta, all this area what you are seeing here, all this area has got a lot of soft tissue, nerves and vessels. So staging investigation of choice for this area, that is oral cancer, this area thyroid cancer, or maybe the breast, because beneath the breast there is pectoralis major muscle. So staging investigation for this oral, thyroid, breast, that will be MRI. But if we talk about esophagus, right, then it is a CECT. If we talk about the entire abdomen, for staging purpose in the entire abdomen, it is CECT. So thorax and abdomen, staging purpose CECT, but breast MRI because of pectoralis major muscle. Okay, once again let's do it beta. Staging investigation for all this area, oral, thyroid, that is MRI, breast is MRI, but otherwise thorax and abdomen it is CECT. So esophagus CECT, stomach CECT, colon CECT, kidney CECT, gallbladder CECT, pancreas CECT. If you move down into the lower part beta, now this lower part is the pelvis. In the pelvis there are a lot of muscles and soft tissues beta. So here again we would like to do MRI. Okay, just look at me on the screen beta. In the pelvic area we are doing MRI. So whether it is a bladder cancer, MRI, prostate cancer, MRI, penis cancer, MRI, right? Rectal cancer, MRI, anal canal cancer, MRI. Okay, let's do it once again beta. Oral thyroid, MRI, breast, MRI. Otherwise the thorax and abdomen CECT, esophagus CECT, stomach CECT, colon CECT, gallbladder CECT, pancreas CECT, kidney CECT. Now when we go into the pelvis, MRI, bladder MRI, prostate MRI, penis MRI, rectum MRI, anal canal MRI. So if they ask you staging investigation, oral cancer, MRI, thyroid cancer, MRI, breast cancer, MRI, esophagus, CECT, stomach, CECT, colon, CECT, gallbladder, CECT, pancreas, CECT, kidney, CECT, urinary bladder, MRI, prostate, MRI, penis, MRI, rectum, MRI, anal canal, MRI, right? So this area CECT, this area and this area MRI, right? So that is how staging investigation can be done. When we want to know the distant spread, दूर दराज के क्षेत्रों को अगर हमें देखना है, if you want to visualize the entire body where the cancer has spread, then we do a PET scan, positron emission tomography, where we use a MCQ isotope, 18 fluorodeoxyglucose, 18 FDG use करते, and we inject this isotope. This is glucose beta, fluorodeoxyglucose, and you know those cells in the body which would be needing more glucose, they will immediately take up this glucose, and the cancer cells, they are rapidly dividing, rapidly multiplying, so they would be needing more glucose, so they will immediately take up this glucose. And when we do a scanning with the gamma camera, we can see the huge uptake of this glucose by the cancer cells. So wherever cancer is present in the body, those cancer cells will take up that 18 fluorodeoxyglucose, and you would be see golden yellow shadows of cancers at whatever area cancer is present inside the body. FDG uptake, right? So this is how various investigations can be done. Now, once we come in the treatment for different cancers, to fight against any cancer, we have got actually 5 options. Herein, we should know that if suppose the cancer has spread to distant areas, अगर दूर दराज के क्षेत्रों में कैंसर फैल गया है, then cure of this cancer would be a bleak possibility. It will not be possible to remove the cancer from all the areas in the body. So in these patients, if we are not able to do a curative treatment, we just do a palliative treatment. Palliative treatment. That means whatever life this patient is having, we will try and do something so that we can make his life as comfortable as possible. Cancers, the biggest challenge is patients come to us late. And if by chance the cancer has spread to distant organs of the body, we will not be able to cure these cancers. And then we just do a palliative treatment. For example, if suppose there is a esophageal cancer, big cancer inside the esophagus has spread to the lungs, to the liver, maybe brain as well. But in these patients, we know that the life may be just 4 months, 6 months. Now, for these 4 to 6 months, if there is a big cancer and a complete traffic jam in the esophagus, you have to give some nutrition to these patients. And to give the nutrition, you cannot just ask the patient to swallow from the mouth. So either you can put a tube into the stomach or tube into the jejunum. We prefer putting a tube into the jejunum, that is a feeding jejunostomy for nutritional purpose. We now can put some stents through the tumor. We can drill holes through the tumor and we can put stent into the tumor, right? If suppose we talk about a stomach cancer, suppose there is a cancer in the distal part of the stomach which is invading into the pancreas and also into the duodenum, and a complete traffic jam is there. Now, we can just connect the stomach with the jejunum, gastrojejunostomy, or you can simply do a feeding jejunostomy, put a tube into the jejunum for feeding purpose. If there is a lady of breast cancer with a fungating cancer in the breast, which might have spread here and there, maybe to liver, lungs, bones, everywhere, we know the life is limited, but she is having a big tumor. She is not comfortable with the tumor. We can simply chop her breast off. Simple mastectomy can be done. This is not for cure. This is just a palliation, so that whatever life the patient is having, at least that duration she can live a little comfortable life. So that is the palliative story. Curative story, because now the awareness of cancers is increasing. So patients can come to us at early stages where the cancer might not have spread to distant organs, distant areas. And then we can remove the entire cancer from this patient. As a doctor, my dear lovely friends, you have got 5 weapons to fight against cancer. You can remove the cancer by surgery. You can give cytotoxic drugs, chemotherapy. You can give radiation therapy, radiotherapy to destroy the cancer. If the cancer is having hormonal etiology, like prostate cancer in males and breast cancer in females, you can give hormonal therapy. Like in prostate cancer, if it is the androgen story, you can do androgen ablation. In breast cancer, if it is the estrogen story, you can do estrogen ablation. And the 5th thing which is coming up nowadays is targeted therapy. Now, because of so many advances at the molecular level, at the molecular genetic level, we are able to identify the growth factor receptors. Which growth factor receptors are responsible for this cancer? And we can have targeted medicines against those growth factors also. That is a targeted therapy. Like in breast cancer, if HER2 new gene is positive, then we give trastuzumab or Herceptin to fight against that HER2 new gene. Any cancer which is having HER2 new gene positivity, you can give that Herceptin or trastuzumab. Just a moment. Right, beta? So we have got the overview. Now, what I want is you to repeat. Okay? Let us see how much you have understood. Tell me, beta. What is the type of cancer in the oral cavity? Esophagus, stomach, colon rectum, anal canal, outer part of the kidney, urinary bladder. Very commonly asked urinary bladder, transitional cell carcinoma. Vagina, ectocervix, endometrium, Good. What are the common risk factors? Oral cancer, tobacco, esophagus, smoking, alcohol, smoked food, and diseases. Stomach cancer, food what we eat, irritative food, spicy food, including smoking, alcohol, high salt, high pickle, less vitamins, antioxidants, plus various diseases in the stomach. Colorectal, what we eat, red meat, animal fat, less fiber, less vitamins, antioxidants, various polyps, right? Anal canal, human papillomavirus, kidney and bladder cancers, smoking, and industry, various chemicals, dyes, prostate cancer, androgen, aging process, penis, poor hygiene, multiple partners, testis, undescended testis, thyroid, papillary, radiation, follicular, long-standing endemic goitis, breast, genetic, familial, long-term estrogen exposure. So these are the common risk factors. How the cancer grows: oral, ulcer, mass; esophagus, mass, polyp; stomach, mass, bleeding; colorectal, bleeding; anal canal, mass, bleeding; kidney, bladder, painless hematuria; prostate, low backache, bony metastasis; penis, growth; testis, scrotal enlargement; thyroid, neck swelling; breast, lump in the breast; circumferential retraction of nipple, bleeding from the nipple; pudiorange, lymphedema. How the cancer spread: locally, if we talk about esophagus, mucosa, submucosa, muscle, adventitia, adjacent organs; stomach, mucosa, submucosa, muscle, serosa, adjacent organs; colon, rectum, mucosa, submucosa, muscle, serosa, adjacent organs; kidney, capsule, adrenal, adjacent organs; bladder, mucosa, submucosa, muscle, adventitia, adjacent organs; prostate, upwards and laterally, may involve the seminal vesicles; penis, corpora cavernosa, and then higher up; testis, scrotum; thyroid, neck; breast, anteriorly skin, posteriorly pectoralis major, pectoralis minor, and the chest wall, that is ribs and intercostal muscles. Now lymphatic spread, beta. Oral cancer, which lymph nodes? Thyroid cancer, pretracheal lymph node; breast cancer, axillary lymph nodes and internal mammary lymph nodes; esophageal cancer, regional lymph nodes; stomach cancer, regional lymph nodes, celiac lymph node; midgut cancers, regional lymph nodes, superior mesenteric lymph nodes; hindgut cancer, regional lymph nodes, inferior mesenteric lymph nodes, right? Kidney cancer, regional lymph nodes; bladder cancer, iliac lymph nodes; prostate cancer, obturator lymph node, and then the iliac lymph nodes; penile cancer, inguinal lymph nodes. Anything which is outside, na beta, whether it is the scrotum or the penis or the perineal skin, that will be draining into inguinal lymph nodes. But inside story will be draining into the iliac lymph nodes. Testicular and ovarian story drains to the pre-paraiotic lymph nodes, right? So testicular lymphatics, pre-paraiotic lymph nodes. Thyroid and breast we have already talked about. Gallbladder cancer, regional lymph nodes; pancreatic cancer, regional lymph nodes. Now through blood, how these cancers will spread. Oral cancer would be going most commonly to lungs, thyroid cancer to bones in the lungs, Breast cancer most commonly goes to bones, the lumbar vertebra, just like the prostate. Esophageal cancer goes to liver, lungs. Stomach cancer, liver, lungs. Colon, rectum, liver most often, right? Kidney cancer going into the renal vein, IVC, lungs. So kidney cancer also goes to lungs. It can also go to bones. Bladder cancer, again draining through the iliac veins into the lungs. Prostate cancer, bones, bony metastasis plus lungs. Penile cancer, again going into the inferior vena cava to lungs. Testicular cancer, again going into the testicular vein, IVC, into the lungs, right? Fine. Now, how to approach these patients depends on the presentation. If there is a growth here, you take a biopsy. If there is a dysphagia, you do barium swallow, and you find something on barium swallow, do a upper GI endoscopy and biopsy. Stomach cancer patient, if there is a mass in the abdomen, do a ultrasound. If there is melena, do a stool test for occult blood. If there is some evidence, then you do a upper GI endoscopy and biopsy. Colorectal cancers, bleeding per rectum, colonoscopy, biopsy. Anal canal cancer, cancer outside the anal verge, take a direct biopsy. Kidney cancer, bladder cancer, painless hematuria, first cytological evaluation of urine to rule out cancer cells. And then pass a endoscope. If there is a bladder cancer, take a biopsy from the bladder, cystoscopy and biopsy. If it is a kidney cancer, you cannot pass a endoscope into the outer part of the kidney. So endoscopy is not possible. You do a CECT, right? For prostate cancer, transrectal prostatic biopsy. Penile cancer, cancer outside, direct biopsy. Testicular cancer, you cannot put a needle, do a CECT. Thyroid malignancy, ultrasound guided FNAC. Breast cancer, lump, CRP, clinical, radiological, pathological. Best is needle biopsy. So now this is how we are approaching these patients. What will be the investigation of choice? Oral, direct biopsy. Esophagus, upper GI endoscopy biopsy. Stomach, upper GI endoscopy biopsy. Colon, rectum, colonoscopy and biopsy. Anal canal, direct biopsy. Gallbladder cancer, CECT. Pancreas cancer, CECT. Kidney cancer, CECT. Bladder cancer, cystoscopy biopsy. Prostate cancer, transrectal ultrasound guided prostatic biopsy. Penile cancer, direct biopsy. Testicular cancer, CECT. Right? Thyroid cancer, ultrasound guided FNAC. Breast cancer, needle biopsy. So this is the investigation of choice. Now to know how far the cancer has spread locally, you know this area, MRI, thorax abdomen, CECT, but breast, MRI, and pelvic area, MRI. So oral cancer staging investigation, MRI. Thyroid, MRI. Breast, MRI. Esophagus, CECT. Stomach, CECT. Colon, CECT. Gallbladder, CECT. Pancreas, CECT. Kidney, CECT. Now bladder, MRI. Prostate, MRI. Penis, MRI. Rectum, anal canal, MRI. So this is how we can do the staging. For distant metastasis for all the cancers, one investigation, PET scan. 18-fluorodeoxyglucose, that will be taken up by the cancer cells wherever they are in the body, and we can see those FDG avid golden yellow shadows, right? Then we can do the staging of these cancers. Once we have done the investigation, we do a TNM staging, right? And based on that, we can decide whether we can cure this cancer or not. If not, palliative treatment. If we can cure, then you have got 5 weapons to fight against cancer: surgery, chemo, radio, breast and prostate cancer, hormones, and targeted therapy against the various growth factor receptors. Right, beta? Fine. So now let us take a look what all is written in the workbook. I hope, beta, you have got the concept of oncosurgery nicely. Without opening the workbook, we have tried to understand these different cancers, and now our life will become easy when we are writing, so that writing we'll be just revising what we have discussed. Right, beta. So now let us take a look in the GI cancers. Let us write something about the oral cancer. Now, most common type of oral cancer is a squamous cell carcinoma. Most common site for oral cancer in India, it is the gingivo buccal sulcus, or the buccal mucosa. Most common site in Western countries. It is the lateral border of middle 1/3 of tongue. Lateral border of middle 1/3 of tongue. And the reason is tobacco chewing. Reason is tobacco chewing. The brown story, what we are seeing here, beta, the malignancy in the brown story area, that will be squamous. This will be squamous cell carcinoma. And the pinky story what we are seeing here, that will be the adenocarcinoma. Even in the gallbladder and pancreas also, it will be adenocarcinoma. Right? This diagram will just help you remember what are the sites for squamous and adenocarcinomas in GIT. Right. So moving further, beta, let us take a look at the different stories of esophageal cancer. If suppose I say that this what we are seeing, this is the esophagus, and here suppose this is the stomach. Now since the lining of the esophagus is squamous, so we are going to find a squamous cell carcinoma. That means generally all this entire upper story here, all this upper story is a squamous carcinoma. Only in GRD patients, because of reflux of gastric contents, the lower story becomes adenocarcinoma, right? So overall, most common malignancy of the esophagus is squamous. However, in Western countries, because GRD is very common, so we find adenocarcinoma. And regarding the site of squamous cell carcinoma, it is the upper 2/3 of esophagus, and especially the middle 1/3 is the commonest site of esophageal cancer. In the upper 2/3 also, it is the middle 1/3 which is the commonest site of esophageal cancer. However, adenocarcinoma, as we can understand, this will be more common in the lower 1/3 of esophagus. So commonest malignancy in lower 1/3 of esophagus is adenocarcinoma. Right. Various risk factors for esophageal cancer, beta: smoking, alcohol, increased consumption of smoked food, betel nut liquid. Those individuals who keep on chewing that gutka, tobacco, or the liquid of that, if they ingest the liquid, then that can cause esophageal cancer. GRD, Barrett's, Eclasia, Zenker's, human papillomavirus, radiation. There is condition called as tylosis. Tylosis is thickening of the skin of the palm or the soles. That is also associated with esophageal cancer. And one syndrome, this SYN is syndrome. One syndrome is associated with esophageal cancer. That is a Plummer-Vinson syndrome. Plummer-Vinson syndrome. The other name is Patterson-Brown-Kelly syndrome. This is basically iron deficiency anemia, glossitis, and esophageal webs. This syndrome is more commonly seen in middle-aged female, and it causes squamous cell carcinoma in the post-cricoid. That means in the upper esophagus. Upper esophagus, post-cricoid region, upper esophagus. It is the squamous cell carcinoma. Right? So there was a question on 4th of June, that which is the common malignancy in the upper part of the esophagus. It is a squamous cell carcinoma. Pathologically, how the esophageal cancer grows, beta, we just talked about that whenever we are talking about esophagus, it usually grows as a polyp. For example, this might be the stalk and this might be the polyp. In the initial stage, this might not be causing any traffic jam, but suppose this polyp increases to big extents and it starts obstructing the lumen, especially more than 2/3 of the lumen, then patient will experience this traffic jam situation, dysphagia. We can very well understand, beta, there will be difficulty in swallowing to the solid food. the liquid can still pass through the side. In eclasia cardia, there was a spasm of the muscle. So when a solid food used to come there, it used to relax the lower esophagus and the solid food used to go down, but the liquid used to get stuck. So eclasia cardia, there is dysphagia initially for liquids, but in cancers, there is dysphagia initially for solids and gradually for both solids as well as liquids. So initially there is dysphagia for solids and gradually for both solids and liquids. Obviously, any traffic jam in the esophagus will have risk of regurgitation, which can lead to aspiration and pulmonary complications. Sometimes hoarseness of voice occurs in esophageal cancer, and that is when the cancer spreads and involves the recurrent laryngeal nerve. This is due to involvement of recurrent laryngeal nerve. Involvement of recurrent laryngeal nerve. And in malignancies, generally we find this anorexia and weight loss. So this is how the esophageal cancer patient would be presenting to you. The age of the patient would be somewhere around 60-70 years. How you are going to approach this patient, beta? Any patient who is coming to you with dysphagia, the first investigation what we do is a barium swallow. Barium swallow. So you are doing a barium swallow. Now in a barium swallow, we know that if it is a case of cancer, suppose here is the cancer in the esophagus. So the contrast which the patient is drinking, that contrast is not going to go into the tumor. That contrast will flow through the side of the tumor. And this will appear as a filling defect. इसमें contrast भर नहीं रहा है. So this is a filling defect. Here you can see nicely there is a cancer here. So you cannot see the cancer here because contrast is flowing through the side of the cancer. And this what you are seeing here, this is called as the rat tail. This is the body of the rat and here this is the tail of the rat. So when you do a barium swallow in this 60, 70, 80-year-old gentleman, you can find a filling defect. Plus you can see a rat tail appearance. Also beta, in cancers of tubular structures in the body, many a times what happens, if suppose there is a circumferential cancer, suppose I say beta, this what you are seeing, this is the esophagus, right? Now if I say there is a cancer which is at the periphery inside, अंदर है लेकिन periphery पे है चारों तरफ, तो सिर्फ only the central part is having the lumen. Now when we give the contrast, we may be seeing this area nicely, but this area where there is a cancer, only a thin rim of contrast will be flowing through the lumen. Something like this. Now here what you're seeing beta, this is something which we see in colon cancer. So if there is a cancer circumferentially on all sides, then only the central part is seen as the lumen. So contrast will be flowing only through this central part. And this appearance what you are seeing, this looks like as if somebody has eaten the apple. This is a apple core appearance. Apple खा के जो बच जाता है ना बेटा, apple core appearance. So apple core appearance is seen in cancers of any tubular structure on contrast study. However, it is more often seen in colon cancer. So we rarely can find this apple core appearance in esophageal cancer also. Herein rat tail is also seen in eclasia cardia. But if rat tail is asked, then cancer esophagus is a better answer than eclasia cardia. So you have done a barium swallow beta and you are seeing something. If you are suspecting esophageal cancer, you have to do a upper GI endoscopy. When you do a upper GI endoscopy, beta, this is what you can see on endoscopy. Can you see this cancer in the esophagus? Now you have to just take a biopsy from this. Upper GI endoscopy and biopsy. For staging purpose, in the esophagus we are doing CECT. There is another investigation, beta, which we are doing for esophagus, stomach, colon, rectum, that is endoscopic ultrasound. Endoscopic ultrasound. That is to know the depth of tumor. Sometimes if you want to know which layers of the organ are involved, whether the cancer is only in the mucosa or it is going into the submucosa or the muscle, then you can just pass a special type of ultrasound. This is the endoscope and this is having the ultrasound probe. Now when you pass this endoscopic ultrasound, as you are seeing here, you're passing this endoscopic ultrasound here. If there is a tumor inside, right? So this, what you're seeing is the lumen, right? This is something which is normal. These are the layers. So this, what you're seeing is the mucosa. Behind this is the submucosa. Behind this would be the muscle layer, right? Now, there is a tumor which you can see growing from the mucosa, and you're not seeing that this tumor is going somewhere into the muscle layer or something like that. So to know the depth of tumor involvement, whether it is esophagus, stomach or colon, we can do the endoscopic ultrasound. Acha beta, so you have taken a biopsy, you have done a CECT, now you want to know about the distant metastasis also. For distant metastasis, beta, the investigation of choice is PET scan. PET is positron emission tomography. Positron emission tomography. The isotope which we are using here is 18-fluorodeoxyglucose. 18-fluorodeoxyglucose. This question has been asked number of times. They can ask FDG, they can ask F, they can ask glucose. So we use this glucose. Right. This is the PET scan, beta. It is a whole body CT scan, right? Where we can do a whole body CT scan. And we have injected the isotope into the peripheral vein. And now when we are taking a look at the pictures, beta, wherever there is cancer activity in the body, those rapidly dividing mitotic cells will be rapidly taking up this glucose. And those areas will appear something like this, the golden shadows, the golden yellow shadows. So this particular patient is actually having a cancer in this part of the esophagus. The cancer is involving a lymph node here. The cancer is involving a lymph node here and a lymph node here. Right? There is no involvement of lungs or liver by this cancer. If suppose the cancer would have spread to the lungs, then you would have seen the golden shadows in the lung as well. Or if the cancer would have gone into the liver, then you might have seen the metastasis in the liver like that. So that is how a whole body CT scan can tell us whether the cancer is involving only that particular area or the cancer is actually spread to the different parts of the body. Right? That is how we read this PET scan. These golden shadows, beta, they are called as FDG avid areas. जहाँ पे FDG का अपटेक हुआ है, FDG avid areas suggest cancer. FDG avid areas suggest cancer. So we have done all the investigations. Now we can stage this cancer beta. So for staging purpose, we use the TNM staging, where T is for tumor, N is for lymph node, and M is for metastasis. TNM. Related to tumor beta, very simple to remember. The cancer starts in the mucosa. So if it has gone into the submucosa, T1, muscle, T2, there is no serosa in the esophagus. So adventitia, T3, and then adjacent organs, T4. Now in the adjacent organs beta, if there is involvement of organs like membranes, pleura, pericardium, diaphragm, then it is T4A. If there is involvement of the solid organs like trachea, bone, aorta, then it is T4B. Right? तो एक बार करेंगे बेटा. T1 submucosa, T2 muscle, T3 adventitia, T4 adjacent organs. T4A pleura, pericardium, diaphragm, T4B trachea, bone, aorta. Right? T1 submucosa, T2 muscle, T3 adventitia, T4 adjacent organs, T4A pleura, pericardium, diaphragm, T4B trachea, bone, aorta. Right? Let's learn this beta quickly. एक बार ऐसे याद करेंगे बेटा. T1 submucosa, T2 muscle, T3 adventitia, T4 adjacent organs, T4A pleura, pericardium, diaphragm, T4B trachea, bone, aorta. Now you have to say from your vocal cords beta. T1, T2, T3, T4, T4A, T4B. Let's do it once again. T1, T2, T3, T4, T4A, T4B, T1 submucosa, T2 muscle, T3 adventitia, T4 adjacent organs, T4A pleura, pericardium, diaphragm, T4B trachea, bone, aorta, T1, T2, T3, T4, T4A, T4B. Wonderful. Very good. Regarding the lymph nodes beta, if only 1 to 2 lymph nodes are involved, that is N1. If 3 to 6 lymph nodes are involved, N2. If 7 or more than 7 lymph nodes are involved, then N3. In GI malignancies, it depends on the number of lymph nodes which are involved, right? And M1 is metastasis, distant metastasis. So N1, 1 to 2, N2, 3 to 6, N3, 7 or more than 7. Right. M1 is distant metastasis. And this is what we are going to do at all the places beta, right? Now we come to the treatment for esophageal cancer. In the treatment, we have got 5 options beta to fight against cancer. Out of these 5, mainstay for esophageal cancer is surgery. And whenever we are doing curative surgery for cancers, we have to take the tumor along with adequate margin all around, so that we don't leave any residual cancer cells behind. Now, what should be the margin which we should take? If we are talking about esophageal cancer now, then suppose I say that cancer is in this area. Suppose there is a cancer in the middle esophagus like this. Length of esophagus beta is approximately 25 centimeters. Suppose I say there is a cancer of 8 centimeter in the middle esophagus. Now it is recommended that you have to take a proximal margin of 10 centimeters and a distal margin of 5 centimeters. That means if the proximal margin is 10 centimeter and distal margin is 5 centimeter, so 10, then 8 is the tumor here, and 5. 10 plus 8, 18 plus 5, 23. Length of esophagus is 25. It is because of this huge margin which we have to take in esophageal cancer that we actually land up in removing the entire esophagus. So the surgical treatment for esophageal cancer is actually a total esophagectomy. पूरा का पूरा esophagus निकाल दिया आपने. Total esophagectomy. Usually we are doing this by a transthoracic approach. Obviously you will be doing a thoracotomy. Thorax खोलेंगे, अंदर जाके पूरा esophagus dissect करके निकालेंगे. This is called as Ivor-Lewis operation. Ivor-Lewis operation. Now, if we take a look at the picture, what we are actually doing here, see beta. Suppose there was a cancer in this area and we have removed this blue shaded area, right? Now total esophagectomy has been done. Now we have to make a new esophagus, and this new esophagus can be made with the stomach. We actually mobilize the stomach in such a way that we make the stomach as a tube, and then we connect the esophagus with the stomach like this and do the reconstruction, right? So total esophagectomy with esophageal reconstruction using the stomach. Early complication what we come across in these cases is wherever we have put the sutures, these sutures can break, anastomosis leaks, and then the contents can spill into the mediastinum, which can lead to pulmonary complications. However, if the anastomosis is fine in the initial phase, maybe after few years, if everything was going on fine, this healing occurs here, fibrosis can occur, and fibrosis can lead to narrowing, that is a stricture can form in this esophagus. So these can be the complications what we can come across. We use stomach is used for esophageal reconstruction. Now, early complication, anastomotic leak, which can cause pulmonary complications. And late complications, stricture esophagus. Late complication, stricture esophagus can occur. Sometimes we can also use chemotherapy. The CTH wherever we are using, this is chemotherapy. In chemotherapy beta, we are giving cytotoxic drugs. Cyto means cell, cell toxic. So these drugs will not only destroy the cancer cells, but they also destroy the normal cells, right? So we have to be very careful when we are using this chemotherapy, because there may be a lot of side effects. Like if you remember, Ae Dil Hai Mushkil, Anushka Sharma, alopecia. So the chemotherapy not only kills the cancer cells but also kills the normal cells. However, we can use 5-fluorouracil, and cisplatin as chemotherapeutic drugs in esophageal cancer. Apart from this, beta, there are two terms, neoadjuvant and adjuvant. Now, neoadjuvant means if you are giving any therapy before the primary treatment. For example, if surgery is the primary treatment for esophageal cancer, and suppose the cancer is too big in size and you feel that surgery will not be possible, you will not be able to remove the cancer. So before doing the surgery, you might give this chemotherapy so that the cancer cells can shrink, and then the surgery becomes easier. So any therapy which is given before the primary therapy, that is called as neoadjuvant. क्या बोलते हैं बेटा? Neoadjuvant. And any therapy which is given after the primary treatment, that is called as adjuvant, right? So if we quickly take a look and summarize the esophageal cancer, beta, छोटी-छोटी सी बातें थी. We discussed that what is the commonest cancer in the esophagus, why the cancer occurs in the esophagus, how the cancer grows, how the patient can present, how we need to approach a patient of dysphagia, and if we come to know something, then what ideally we should do, how to know about the spread of cancer, how to know about the spread into the depth of layers, how to know about distant metastasis. Once we have done all the investigations, we come to know how far the cancer has spread, we can do the staging, the TNM staging can be done, and then the treatment. In the treatment for esophageal cancer, for surgery, we have to take an adequate margin. So proximal 10 and distal 5, right? Now if we talk about the stomach cancer, beta, in the stomach, we know this is all going to be lined by columnar. So this is going to be adenocarcinoma. So most common malignancy inside the stomach, beta, adenocarcinoma. Whether it is India or Western countries, it will be adenocarcinoma. Most common site, if we take a look, beta, Helicobacter pylori is a common culprit in developing world. And Helicobacter pylori, bhai sahab jo hai, he lives in the pre-pyloric region. So the commonest site of malignancy inside the stomach is actually the pre-pyloric region. Most common site of malignancy in the stomach is the pre-pyloric region. However, in Western countries, majority of malignancies are related to reflux, gastroesophageal reflux. That means when the acid will be refluxing, then it will be this particular area which will be bearing the major brunt. So in Western countries, it is the cardia of stomach. In Western countries, it will be the cardia of stomach which is more common. That means, beta, just to summarize and remember, if we talk about the Western countries, here is the gastroesophageal junction, suppose. If we talk about the esophageal and the stomach cancer in Western countries, then since Western countries cancers are more commonly associated with GERD, so when we say esophageal cancer, the cancers will be found near the gastroesophageal junction, that is the lower esophagus, and stomach cancers will be found in the cardia of the stomach. That means Western countries, this diagram might help in making you remember that Western countries malignancies are more common with GERD. So lower esophagus and cardia of stomach. That is the common site of malignancy in Western countries. Acha beta, if we take a look at the various risk factors, smoking, alcohol, high salt, high pickle, smoked food, canned food, less vitamins, antioxidants. A common culprit for stomach cancer is this bacteria, Helicobacter pylori. Even there is a virus, Epstein-Barr virus. Epstein-Barr virus, which is a common culprit for the stomach cancer. So one bacteria and another virus, they are also common culprits for malignancy in the stomach. Then if we take a look at the different pathologies, there is a autoimmune or atrophic or type A gastritis, where antibodies are formed against the parietal cells, and that leads to cancer in the fundus of the stomach. Type B gastritis is H. pylori, Meniere's disease, reflux gastritis. This is a patient who has undergone previous gastric surgery. Just to remind you, beta, if this is the esophagus and this is the stomach, suppose you have removed this part of the stomach. Now what we do is, we are left with only this part of the stomach. Now we cannot connect it with the duodenum. We actually bring the jejunum and we make the connection with the jejunum. So whenever you have connected the stomach with the jejunum, you know this is a gastrojejunostomy. There is no sphincter at the junction. So the gastric contents will be coming into the jejunum and jejunal contents will be refluxing into the stomach. Jejunal contents are alkaline. So alkali reflux in the stomach will cause damage to the stomach mucosa, intestinal metaplasia, and that can lead to cancer. Even gastric ulcers should be considered as malignant unless proven otherwise. So they are also associated with the risk of cancer. Adenomatous polyps associated. Genetic factors like P53, SMARCA1 and ROA, they can be associated with stomach cancer. Pathologically, if we try to take a look at how the cancer grows inside the stomach, there can be a growth, there can be an ulcer, or sometimes there is a diffuse cancer inside the stomach, which involves the entire stomach. This diffuse stomach cancer, which involves the entire stomach, this is called as Linitis plastica or a leather bottle stomach. Right? Diffuse stomach cancer. This is a leather bottle stomach or Linitis plastica. Herein, this is asked as an image-based question. What is happening in this case, beta? The stomach was like this. Suppose the stomach was like this. But what has happened here is, because the cancer has developed inside the stomach, so all this area what you are seeing, there is cancer here. And now when you are doing a contrast study, the contrast is just flowing through the lumen of the stomach. That is why on contrast study you are seeing only the lumen of the stomach. Other things you are not seeing. So this is how the contrast is seen. This simply means there is a diffuse gastric cancer. This is just like a leather bottle stomach or Linitis plastica. We can classify these cancers as early and advanced. Now early is actually a Japanese classification and advanced is actually a Borman classification. What is early and what is advanced stomach cancer? You know the different layers in the stomach: mucosa, submucosa, muscle and serosa. If only mucosa, submucosa is involved, we call it early. If the muscle is also involved, we call it advanced gastric cancer. Irrespective of lymph node involvement, lymph node may or may not be involved. That means if only mucosa, submucosa is involved, that is early. If mucosa, submucosa and muscle is also involved, then we call it as advanced. Lymph node may be involved in early or advanced. Then there is a molecular classification. In molecular classification, We can classify them into 4 types: Epstein-Barr virus positive, microsatellite instability, genomically stable, and chromosomal instability. How these gastric cancer patients can present to us, beta? They can present as a mass, what we were talking about. They can present as melena or hematomasis, anorexia, weight loss, may be involving the lymph nodes, so lymph node enlargement would be there. A Trousseau sign can be seen in stomach cancer. This is actually migratory thrombophlebitis. Migratory thrombophlebitis. What happens, beta G? In malignancies, there are certain cancers which produces certain substances which changes the property of platelets. So the chances of inflammation of the veins increases because of aggregation of platelets here and there in the veins. Most commonly, this Trousseau sign is seen in pancreatic cancer. Most commonly, Trousseau sign is seen in pancreatic cancer. How the stomach cancer can spread, beta, we have talked about through local lymphatics, blood, and a transcoelomic spread. Locally, dekhte beta, if suppose I say that this is the stomach, what you are seeing, and now suppose there is a cancer in the proximal part of the stomach. Here you know there is spleen. This what you are seeing is the spleen. And here what you are seeing is the pancreas. If there is a cancer in the proximal part of stomach, there are chances to involve the spleen. However, if there is a cancer in the distal part of the stomach, then there are chances to involve the pancreas. So proximal gastric cancers, most common adjacent organ involved is spleen. Distal stomach cancer, most common adjacent organ involved is pancreas. Just give me a moment. Right, beta. So, through lymphatics, the principal lymph node for foregut malignancies will be celiac lymph node. And through blood, most commonly it will be going into the liver. Also, one thing which we discussed, beta, about the transcoelomic spread or the direct peritoneal spread. Now, if you look at this image, beta, if suppose there is a stomach here and there is a cancer here, sometimes these cancer cells can break from the stomach and they can spread here and there in the peritoneal cavity. If they are lying on the peritoneal surface, they are called as peritoneal seedlings or peritoneal deposits. If these cancer cells, they collect around the umbilicus, periumbilical tumor deposits, they are called as Sister Mary Joseph nodule. Can you see this nodule here, beta, around the umbilicus? This is a lady of gastric cancer presenting with nodules around the umbilicus. This is a Sister Mary Joseph nodule, right? That is because the cancer has spilled in the peritoneal cavity and the cells have collected around the umbilicus. If the cancer cell deposit on the ovary, Krukenberg tumor. If they deposit on the rectal wall, Plummer's shelf, right? So peritoneal seedlings or deposits. If the cancer cells deposit around the umbilicus, periumbilical tumor deposit, beta, this is a very hot question, very commonly asked. Sister Mary Joseph nodule. Ovarian tumor deposits, called as Krukenberg tumor. And rectal wall, Blummer's shelf. Sometimes through the lymphatics beta, the stomach cancer that can spread to the left supraclavicular lymph node. This what you are seeing. This is the Virchow's node or the Troisius sign. Virchow's node or the Troisius sign. Actually, the stomach cancer first spreads to the perigastric lymph nodes, and then it spread to the celiac lymph node, and then it can go into the left supraclavicular lymph node, which is called as Virchow's node. This is the Troisius sign. Troisius sign. Sometimes the cancer cells can involve the axillary lymph node, and that is called as a Irish node. The toughest exam in the history of FMG, June 2014, when the pass percentage was 4%. The exam was conducted on 2 days, 28 June and 29 June. 28 June, they asked Virchow's node. 29 June, they asked Irish node. Right. So this is the overview about stomach cancer. Now, how to approach these patients? If the patient presents with melena, first we have to do a stool test for occult blood. And if occult blood is positive, then we have to do a upper GI endoscopy and biopsy. Because if the patient is presenting with melena, then the bleeding has to be from upper GI tract. You do a upper GI endoscopy, and if you see a mass in the stomach, you can take a biopsy. If the patient presents with a mass in the abdomen, first investigation will be ultrasound of the abdomen. If on ultrasound you see a mass, then you do a upper GI endoscopy and you can take a biopsy. So beta, what will be the investigation of choice for stomach cancer? It will be upper GI endoscopy and biopsy. This will prove that yes, you are dealing with a cancer. To stage the cancer beta, this is the abdomen. So you can go ahead with CECT. अपने को पता है ना बेटा, thorax abdomen में staging के लिए CECT and depth के लिए endoscopic ultrasound. Distant metastasis के लिए PET scan. Which isotope we are using in PET? 18-fluorodeoxyglucose. So that is how we'll come to know how far the cancer has spread. And based on this, we can do a TNM staging. Please remember, in GIT cancers, N stands for number of lymph nodes. And here, what you can do is, you can just start remembering the esophagus, T1 submucosa, T2 muscle, T3 adventitia, T4 adjacent organs, T4A pleura pericardium diaphragm, T4B trachea bone aorta. Stomach also, T1 submucosa, T2 muscle, T3. Here there will be serosa beta, no adventitia, here there is serosa. So T3 is subserosa and T4 is penetrate the serosa, perforate the serosa, and T4B is involvement of adjacent organs. So T1 submucosa, T2 muscle, T3 subserosa, T4A perforate the serosa and T4B adjacent organs. Lymph node, same story beta, N1 1 to 2, N2 3 to 6, N3 7 or more than 7. However, N3 can be classified into A and B. 7 to 15 A, more than 15 B. And M1 is distant metastasis. The treatment for stomach cancer, beta, again the mainstay of treatment is surgery. And the margin of resection around the tumor which we need to take is 5 centimeter. Now just have a look, beta, here. If suppose I say there is a cancer in the proximal part of the stomach. And now if you have to take a 5 centimeter margin, so you will be taking a 5 centimeter margin like this, like this. If you chop it like this or like this, you will be left only with this part of the stomach. So इतने से stomach को छोड़ के कोई एहसान करने की जरूरत नहीं है इस पे. In proximal stomach cancers, it is better to chop the entire stomach. So for proximal gastric cancers, we are actually doing a total gastrectomy. And in this, we offer a scheme to the patient. स्टमक के साथ साथ स्प्लीन को बिना किसी एक्स्ट्रा चार्ज के निकाला जाएगा. So we do a total gastrectomy with splenectomy in proximal gastric cancers. But if I say that suppose there is a cancer in the distal part of the stomach, so if there is a cancer in the distal part of the stomach, and now when you have to take a 5 centimeter margin, so you can take a 5 centimeter margin like this, and by doing this, you will be able to preserve this part of the stomach. So instead of doing a total gastrectomy, for distal stomach cancers, we prefer doing a partial gastrectomy. Partial gastrectomy. And this is also called as subtotal gastrectomy. So this is the treatment what we are doing for stomach cancers. Right, beta? So this is all about the stomach cancers. Now, I would request all of you, beta, that we are taking a break here due to some work. I'll have to leave, and I think I would be back somewhere around 4 o'clock. So we will be starting our next session at around 4 o'clock. Okay, if there is any delay, I'll definitely communicate to you. By this time, I would just like you to see this session once again. Every one of you, beta, ध्यान से सुनेगा इस बात को. Every one of you, please see that session once again, where we did not have any workbook. There was a black screen, and we were just trying to make the concepts. Look at that once more whenever you get time in these 2 hours 15 minutes. Thank you very much for your patience. May God bless you. Wish you all the best, and let's meet at 4 o'clock in the afternoon. God bless you. Bye-bye.